Good evening and welcome everyone to tonight's webinar event, Incorporating Liquid Biopsy into the Diagnostic Algorithm for Metastatic NSCLC. We want to thank AstraZeneca for sponsoring this webinar event and for being 2023 SAB sponsors. Dr. Michael Pritchett is this evening's moderator. Dr. Pritchett is with First Health of the Carolinas and Pinehurst Medical Clinic. He is one of the SAB's past presidents. At this time, I'll hand it off to Dr. Pritchett to get us started, and thank you everyone for joining.
Thanks, Emily, and welcome everyone to this sponsored webinar by AstraZeneca, presented to you by the Society for Advanced Bronchoscopy. Tonight, I'm proud to introduce a couple of our expert panelists, Dr. Charu Agarwal and Dr. Jeffrey Thompson from the University of Pennsylvania, are both medical oncologists and experts in precision medicine and thoracic oncology. We're going to talk tonight about how to incorporate liquid biopsy into our diagnostic algorithm for specifically metastatic non-small cell lung cancer. Let's have you guys both introduce yourselves real quick, and we'll start with you, Dr. Agarwal.
Thank you, Dr. Pritchett. I'm Charu Agarwal. I'm the Leslie Heisler Associate Professor for Lung Cancer Excellence at the University of Pennsylvania's Abramson Cancer Center. I lead the clinical trials program at our center, as well as I'm the Associate Director for Penn Center for Cancer Care Innovation.
And thank you. And I'm Jeffrey Thompson. I'm an assistant professor of medicine in our section of interventional pulmonology at the University of Pennsylvania. And I'm a translational researcher with a focus on precision medicine in non-small cell lung cancer.
Great. Well, thanks for joining us tonight. And I'm Michael Pritchett. I'm a pulmonologist in Pinehurst, North Carolina, in a community setting. I'm happy to moderate this talk tonight. Next slide, please. This is our disclaimer that we have to mention. These are all of our own opinions from our own experience tonight from our various institutions, and they don't reflect the opinion of AstraZeneca, although they're the sponsor of tonight's program. Next slide, please. All right, this is the program for tonight. We'll skip right through this and go to the next slide, and we'll let Dr. Agarwal get into our introduction. Take it away, Dr. Agarwal.
Sure, thank you so much. And I think without further ado, we'll get started with this program. I think I wanted to really emphasize reductions in lung cancer mortality. I think this has been accelerated in part by precision medicine efforts that have driven therapeutic options as well as delivery of therapeutic agents. As you can see on the figure on the left, in the United States itself, deaths from the most common type of lung cancer fell by 3.2% each year between 2006 to 2013, and then from there onwards, it has been steadily declining at a steady rate of 6.3% each year. Much of this has been driven by, as you know, targeted therapy. Next slide. Treatment driven by diagnostic testing has been found to correlate with overall survival. The curves here depict a very large database of patients of whom many of them underwent biomarker testing. I want to say a majority of them did undergo biomarker testing in the entire population. But then when they looked at the differences in survival, they found that those that had undergone biomarker testing had a much longer overall survival. Next slide. And it's important because biomarker testing can help us really drive this idea of precision medicine and personalized therapy in patients with metastatic non-small cell lung cancer. Now, in the real world, in my clinic, in the first-line setting, I have to test for at least 9 actionable mutations so that I can properly and appropriately deliver therapy. You can see on this figure on the left, there are several different sensitizing mutations. In my experience, there are 7 big ones: EGFR, ALK, ROS1, BRAF V600E, MET exon 14 skipping mutations, RET, and NTRK. For these, we have a drug that can be administered in the first-line setting. There are some other mutations that still inform therapeutic decisions, such as KRAS G12C, EGFR exon 20, HER2 mutations. And I think it's just important to recognize that it's a heterogeneous disease. When we look at delivery of treatment, when we look at decision making, we must ensure that we are personalizing therapy. NCCN guidelines in oncology recommend comprehensive molecular testing for all eligible patients with metastatic lung cancer, including at least these genes. Although in my clinics, we do comprehensive gene sequencing that includes usually a larger panel that gives us information about other biomarkers as well. Next slide. There are a lot of challenges in biomarker testing, and we won't be having this seminar if we didn't have challenges. But first, to highlight the disparity in testing, looking at real-world analysis, many of the patients actually don't get even a minimum of five biomarker tests. On the left from a table, you can see this was a large study that looked at over 3,000 patients. They looked at single gene testing, and they looked at proportion of patients that had at least 5 biomarkers tested. And you can see less than half of the eligible patients are getting tested. So most patients actually in the real world are not getting even a chance at personalized therapy or precision medicine. Next slide. There are multiple reasons for this, and multiple practice gaps may actually contribute to biomarker testing challenges. If you start with me on this figure on the left, you can see there are several challenges in even getting a patient to get a biopsy. So that may be practice gap 1. There may be challenges with actually processing the biopsy. Another gap may be that there may not be sufficient tissue for analysis may be required. Another gap is that even if tissue was appropriately collected, patient was sent for biopsy, tissue is adequate, if the test is never ordered, it's never going to get done. And then inconclusive results or inconclusive testing is definitely a problem. So on this study, a retrospective analysis of data for metastatic non-small cell lung cancer patients found that if you start with 100% of the patients to begin with, only about 23.2% actually make it through. And you can see that these numbers can fall through several different places. If we go to the next slide. So we have some barriers, as we discussed even in the previous slide. But if you look at this in a more simplified fashion, there are both patient level and physician level barriers. So on the patient level side, there is a knowledge gap. Many patients come to me and they want to get started on treatment as soon as possible. And there's this urgency to start treatment. There also may be physician-based barriers such as clinical inertia. We talked a little bit about tissue barriers, and then finally, lack of institutional resources. Next slide. So if we look at the first barrier of tissue QNS, this is where liquid biopsy really comes in. So if you go to the next slide, we have done a lot of work in terms of utility of liquid biopsy at the time of initial diagnosis of patients with metastatic lung cancer. So the gold standard is to use tissue-borne diagnosis, but we now know that tumors secrete circulating tumor DNA or shed circulating tumor DNA. There are different approaches of combining liquid biopsy with tissue biopsy, or I should say liquid biopsy sequencing with tissue sequencing. There can be a sequential approach where we do the tissue sequencing first, followed by liquid, if in case the tissue is inadequate, or we can look at a complementary approach where we do both. And then finally, there's another approach where you may do a plasma first approach, where you come in with liquid biopsy first and then go for tissue. In my clinic, we sort of have landed on a complementary or concurrent approach. So if we go to that next, this is based out of data coming from our university, and Dr. Thompson, who's also on this call, was integrally involved in this effort. Next slide, please. We looked at patients with advanced non-small cell lung cancer, 323 patients that were enrolled. Our intent was to perform concurrent plasma and tissue sequencing. We had the hypothesis that by layering in liquid biopsy, we'll be able to increase the number of actionable mutations. And here you can see that out of our 323 patients, even though our intent was to perform concurrent testing, we were able to perform concurrent testing in only about a third. And this is at a large tertiary care, university level hospital. And the reasons why patients didn't get concurrent testing were, well, firstly, liquid was the only thing that was possible. So sort of in the middle block, the tissue of interest was, or the site of interest was really too deep. So in my experience, like it was an adrenal met, we couldn't really reach it. It was unsafe to do the biopsy. And about a third of the time, patients or physicians said, can I just use something that's more accessible? We go to the next slide. We found that once we layered in plasma and tissue sequencing together, we were able to increase detection of actionable alterations from about 20.5% using tissue alone to 35.8%. But the bottom line is that we were able to identify more patients with actionable mutations compared to using tissue or liquid biopsy alone. I think this is a very meaningful message because with a simple intervention, we're able to actually now bring the idea of precision medicine forward. Next slide. If we talk about lack of resources, there can be lack of institutional pathways, or there can be lack of resources in general. I think we talked a little bit earlier in terms of physicians have to order it sometimes. So if we go to the next slide. We have a reflex testing panel at the University of Pennsylvania that I wanted to highlight that has really accelerated our ability to perform molecular testing in a more automated fashion. So for example, if a patient walks in with a possible diagnosis of metastatic lung cancer, my colleague, Dr. Thompson, will take them to the OR, do a bronchoscopy, and then as soon as a diagnosis of non-squamous, non-small cell lung cancer is made, our pathologists direct the sample to go to the molecular pathology lab where reflex tissue NGS automatically is performed in conjunction with the rest of the process that the patients have to go through, meeting with the medical oncologist, so that by the time I meet them, their tissue sequencing is either already complete or in process. I usually order liquid biopsy at the time of initial visit and then see them back in about 7 to 10 days. At that time, I usually have both the tissue and liquid sequencing back. So this is a good example of how it works well. And this really came about through a multidisciplinary team effort. Next slide. We've shown that concurrent tissue and plasma genotyping may actually improve survival in patients with newly diagnosed stage 4 non-squamous non-small cell lung cancer. We firstly found that if we used concurrent liquid and tissue sequencing, that our likelihood of getting those results back was much faster. And then finally, we found that patients that underwent comprehensive molecular sequencing as defined by NCCN had significant improvements in overall survival. And then I think it's one thing to do a test, but it's another thing to actually apply the test results to your patient. So we analyzed if availability of genotyping results prior to first line was associated with improvement in survival, and we found an even more significant difference. So this is kind of intuitive, about 24.5 months with availability of results compared to 6.5 months amongst those who didn't have results available. So if I know that a patient has a mutation, I'm more likely to offer them targeted therapy. And the last thing I want to talk about is this issue of clinical inertia. In my experience, medical oncologists are really busy. We are being asked to do 1,000 clicks in a minute. We are being asked to see multiple patients, and we are also supposed to remember all of these guidelines in our head. So we wanted to really make it easy for physicians to do the right thing. Oncologists are trying to do the right thing, but ordering liquid biopsy is yet another step. So next slide. So what we designed was a nudge intervention at our institution at Penn. We designed an electronic medical record-based workflow where our new patient navigators would ask and look at the records. And if there were 3 criteria, if a patient had a new diagnosis, they were treatment naive, or they had a diagnosis of metastatic non-squamous non-small cell lung cancer, it would trigger a provider-focused nudge intervention, which would automatically place an order for a plasma gene sequencing order that would be placed, and the patient would get it at the time of the first initial visit. And we also paired it with a decision support where myself and my colleague reviewed each report for our patients coming through so that we could really look for actionable targetable mutations and send in email reflex alerts to really guide the appropriate therapy. We intentionally wanted to conduct this exercise not just at an academic institution, but 2 community-based sites were chosen so that we could really improve and see, can we actually replicate this in a community-based setting amongst physicians who don't just see lung cancer. Next slide. We found a few interesting things. Firstly, over a course of a year and a half, we were able to find that this nudge intervention was feasible. It was easily replicable at these community sites. Secondly, the simple nudge, which can be introduced into the electronic medical record, was actually associated with an increase in comprehensive gene sequencing. So on the left, you see proportion of patients with comprehensive gene sequencing overall, pre-intervention in maroon and post-intervention in blue. You can see there's a delta at even the academic sites. We actually reached 100% comprehensive gene sequencing amongst all our patients. But I want to point out the delta at our community sites. We went from 70.6% to 93.8%. And then, as I discussed with you, testing is one thing, but really getting the results back before first line is what really matters. And you can see the difference in the community is really striking. In my experience, it's getting the team together. It's getting the new patient coordinator involved. It's getting the nurse navigator involved. It's taking the burden away from the physician. It's really helping them do the right thing, order the right test. We found that there was significant increase in proportion of patients with comprehensive gene sequencing prior to delivery of first-line therapy. Next slide. So with that, I'd like to open with a case, and then I'll hand it over to Dr. Pritchett. This is something that comes up again and again, and I think it's important to highlight. A 67-year-old female has a remote 10-pack-year smoking history, presented with shortness of breath, was treated with pneumonia. And as you can see on the CAT scan, we found a left upper lobe mass. There was hilar lymphadenopathy. We performed a PET scan that is shown here, as well as an MRI of the brain. There was presence of metastatic disease due to the presence of brain involvement, but the PET scan actually showed no other evidence of disease. An EBUS FNA was performed of this lymph node. It showed us poorly differentiated carcinoma consistent with adenocarcinoma with a PD-L1 level of 90%. And a tissue NGS was unfortunately QNS. So we sent our liquid biopsy, as has been our practice, and unfortunately we found no ctDNA.
All right, so on the next slide, let's open up for some discussion here on this case. So you have a patient with metastatic disease. They have brain metastasis. Their tissue NGS was QNS. So of course it wasn't Dr. Thompson's case. Definitely. We know he always gets enough tissue. But it does present this case, and for a variety of reasons, we may have a tissue result that is quantity not sufficient. So the question is how often are liquid biopsy samples coming back as insufficient? And then the follow-up question from that is that okay? Is a negative plasma test really negative?
Yeah, I can take the first crack at that. I think that's an important distinction to make, in that plasma gene results are very informative when you detected a specific driver mutation. If a specific driver mutation is detected in the plasma, you can assume that driver mutation is also present in the tissue and then can act on that. Where you really need to be careful is when you don't detect a driver mutation via plasma genotyping, because unlike tissue, there are various contributors to the degree of shedding of circulating tumor DNA into circulation, therefore the ability to detect such mutations. So you have to take into account tumor burden, whether someone has extensive tumor burden, which has been demonstrated to correlate very well with the allelic fraction of various mutations that are detected via circulating tumor DNA. The tumor histology can correlate with the degree of circulating tumor DNA shedding. The metastatic localization, where disease is confined to the chest versus outside the chest, can correlate whether you're able to detect specific mutations. And so you have to factor all those things into consideration. And our practice has really been to generally, if you don't detect a specific driver mutation in circulating tumor DNA, that you have to assume that that's a false negative and move forward with more invasive testing for tissue sequencing.
Yeah, and in my experience, I would just like to add that, if we see absolutely nothing detected, that's a sign that, the disease is just localized, there's not enough ctDNA in the circulation, or there is, that our test is just not deep enough or, sensitive enough to go down that low to that level of detection. So in those situations, this example is really important to remember that a negative ctDNA doesn't mean that there's absence of gene mutations. And in my clinic, these situations are challenging for us because obviously, we are hoping that either using the complementary approach, that using at least both of them simultaneously, will be able to get an answer with one of them. But I want to just highlight that for somebody like this with a minimal smoking history, we should continue to look for mutations. This is, we should not just be driven by that PD-L1 90%. We should really go back and, make another attempt, go for the left upper lobe, or try CT-guided biopsy approach, and we will often go in and rebiopsy.
Yeah, I think those are all great points. And, in this case specifically, they have a tiny 3 millimeter brain met. So, they don't have widespread disease. Maybe there's not. We also have to recognize that as excellent as, plasma and liquid biopsies are, there's limitations too. In my experience, if you have a 45-year-old patient, never smoker, I would not take that negative ctDNA test to the bank. But I think it also highlights the importance of doing these together. And you presented your own data that has shown, when you combined tissue and plasma, you're going to get more actionable results, because there's times where you'll pick up things on plasma that you didn't on tissue, and then vice versa, although we know tissue is certainly the gold standard. So, what best practices can we do to help ensure that we get adequate tissue for biomarker testing? And I'll point the finger here at Dr. Thompson. What are you guys doing? Do you know your QNS rate? Do you think it's important for, pulmonologists and thoracic surgeons to know what their QNS rate is?
Yeah, I think that's a great question. I think this is a critically important question. I think it's really critical for pulmonologists and thoracic surgeons to be thinking about biomarker testing and understand, biomarker, we're no longer in the days of you just have to get a tissue diagnosis. Like now we've kind of moved into the, era of precision medicine, and we have to get a tissue diagnosis as well as get sufficient tissue for, downstream biomarker testing. And so, being knowledgeable about the specific, biomarker tests that need to be performed, the substrates that can be utilized for such testing, such as surgical pathology or cytology specimens, and then working very closely with your, pathologist to understand, like what is it they need, what are the limitations to getting, adequate tissue to ensure that your biopsies are adequate for, diagnostic purposes and downstream biomarker testing. At our institution, we really have a very close relationship with our pathologists and understanding, the adequacy of our biopsies, what tests need to be performed, whether we're using SurgPath or cytology specimens. And that's been, a critical feedback loop, to improve our performance over time, to making sure that, we're able to deliver, the right, biopsies for our patients to ensure that they can receive precision medicine.
Yeah, it's definitely a team effort. And I like how you point out that interaction with pathology. At our institution, we have rapid on-site pathologic evaluation, and they're fantastic at talking with us. And so that's the feedback that we rely on, so that the same day I can say, we're going to draw a liquid biopsy today. Because my goal at my institution is, before they ever sit down with someone like Dr. Agrawal, I want them to have at least the liquid results already in hand, if not the tissue. So hopefully that's what we're trying to strive for. And I know not everybody has rapid on-site pathology, but I think that you're absolutely right that this is a multidisciplinary approach, and that's kind of the focus for this whole talk. Anything to add here, Dr. Agrawal, before we go to the next section?
No, I think you captured it beautifully. I think it's a multidisciplinary discussion. I think we have to be all in. It's not just pulmonologists, but also pathologists, I think surgeons, as well as radiologists.
Yeah, absolutely. All right, next slide, and we'll hand it over to Dr. Thompson.
All right. I think that, Dr. Agrawal highlighted a number of the barriers that we see for achieving appropriate biomarker testing for our patients with metastatic non-small cell lung cancer. But, one of which is, a knowledge gap about, the when to order, specific biomarker testing, and that there really is an urgency to start treatment for our patients. Next slide, please. So Dr. Agrawal already highlighted the clinical pathway that we have at our institution, where, when we see a patient here on the left with a possible diagnosis of metastatic non-small cell lung cancer, those patients then undergo a biopsy. And then when the biopsy is demonstrated to have a non-squamous non-small cell lung cancer, that tissue is automatically reflexed to a tissue next generation sequencing panel that's in-house. And that panel can take anywhere from 21 to 28 days to return its results. And it's usually within this time frame that the patients are meeting with the medical oncologist for the first time. And as I mentioned, these patients have often undergone, a prolonged diagnostic journey to be ultimately diagnosed with metastatic non-small cell lung cancer. And here they've been finally waiting to meet the medical oncologist and formulate a treatment plan. Whereas I think that first medical oncology visit is usually, going through all the various treatments that are currently available for patients with metastatic non-small cell lung cancer, and then telling the patient, well, to really inform the best treatment, for you and your cancer, we still need a couple of weeks until all, the biomarker testing is available, so that we can make the, best treatment decision possible. And, Dr. Pritchett, just mentioned that, his goal is really, in the OR, if he sees that there's going to be insufficient tissue for downstream biomarker testing, then he'll go ahead and order that liquid biopsy. And so we were really interested in that question as well, is could we, perform tissue biopsy and liquid biopsy simultaneously, and would that decrease the time to which patients received effective treatment initiation? So we really hypothesized whether we can incorporate early use of plasma next generation sequencing into the clinical pathway ultimately would reduce the time to treatment. So next slide, please. So we really designed a clinical trial with plasma genotyping at the time of diagnostic tissue biopsy to determine whether this would decrease time to treatment in patients with advanced non-small cell lung cancer. There were two cohorts in this prospective study. The first was the cohort 1 here in the pink. This was the prospective cohort where patients were enrolled who were suspected of having stage 3B or stage 4 non-small cell lung cancer based on cross-sectional imaging. These were patients being evaluated in our interventional pulmonology clinic for diagnostic biopsies, and then patients were excluded that had other active malignancies. And then we compared this to a retrospective cohort, which included 55 patients that were consecutively enrolled in the year prior to the trial initiation. And our primary outcome was really time from diagnostic tissue biopsy to the selection of a first-line systemic therapy compared to our retrospective cohort. You can see here at the bottom in blue, this was our retrospective cohort. As I mentioned, it was 55 patients with advanced non-small cell lung cancer. that were enrolled in the 12 months prior to the enrollment in our prospective cohort. And then here in the pink is our prospective cohort, which included 65 patients with suspected advanced non-small cell lung cancer. 10 were ultimately found not to have non-small cell lung cancer, the vast majority of which turned out to have small cell lung cancer, which I think is difficult to discern just based on imaging alone. But you can see the clinical pathway that these patients followed. They had cross-sectional imaging that was suspicious for advanced non-small cell lung cancer. They underwent a tissue biopsy as well as simultaneous plasma sequencing. They had non-small cell lung cancer diagnosed. They had reflex PD-L1 testing as well as reflex tissue next generation sequencing, and then we compared the outcome across these two cohorts. Next slide, please. You can see the baseline characteristics between the two cohorts. So cohort 1 is our prospective cohort, and cohort 2 is our retrospective cohort. You can see here the cohorts were well balanced with regards to age, sex, race, smoking history, histology, and first-line treatments received. Next slide, please. And then importantly, the number of actionable oncogenic driver mutations detected was really similar in both cohorts. So you can see this was 62% in cohort 1 compared to 64% in cohort 2. You can see by the bar charts here, this is cohort 1 with the different driver mutations detected labeled in different colors. And you can see that you had pretty similar number of oncogenic driver mutations detected across the two cohorts. So you can see in cohort 1, more specifically, we had 2 ALK fusions, 1 BRAF mutation, 2 ERBB2 exon 20 insertions, 13 EGFR mutations, as well as 13 KRAS mutations, which included 5 KRAS G12C mutations, 2 MET exon 14 skipping mutations, and then 1 RET fusion. And importantly, what we demonstrated here is that a therapeutically informative driver mutation was detected in the majority of patients in both cohorts, suggesting that plasma genotyping at the time of diagnostic biopsy may help inform treatment decisions in a significant percentage of cases. Next slide, please. We first wanted to look at whether the time to when patients saw the first medical oncology visit was different across the two cohorts to see if that might impact our results. And you can see in cohort 1 compared to cohort 2, the median time from diagnostic biopsy to first medical oncology visit did not differ significantly between the two cohorts. This was 12 versus 14 days. And then we evaluated the availability of next-generation sequencing results at that first oncology appointment. So as I mentioned, in the current landscape where we're just focusing on tissue next-generation sequencing, I think the vast majority of patients do not have those molecular sequencing results available at that first medical oncology visit. And that's exactly what we found. In our prospective cohort, which is the cohort that included plasma genotyping being performed at the time of tissue biopsy, 85% of patients in our prospective cohort had next-generation sequencing results available at that first medical oncology visit, compared to only 9% of patients in our retrospective cohort. So we were able to demonstrate that a significantly higher percent of patients in cohort 1 had next-generation sequencing results available at the first medical oncology visit. This was mostly driven by the availability of plasma next-generation sequencing results, as the turnaround time for plasma next-generation sequencing was shorter compared to tissue. The median turnaround time for plasma sequencing was 8 days compared to 26 days for the tissue sequencing. Next slide, please. So we next wanted to look at whether treatment was initiated at that first medical oncology visit and whether that differed between the two cohorts. And indeed, what we found was that more non-small cell lung cancer patients with plasma genotyping performed at the time of initial diagnostic biopsy received a specific treatment recommendation during that first medical oncology visit. So you can see in cohort 1, 74% of patients that had plasma genotyping at the time of a diagnostic biopsy received a specific treatment recommendation during their first medical oncology visit, compared to only 46% in our retrospective cohort. And then finally, we wanted to see whether performing this decreased time to treatment initiation. And indeed, we found that performing plasma genotyping, the time of diagnostic tissue, does indeed decrease the time to which patients receive effective therapy. So when we looked specifically at those patients that had an oncogenic driver mutation identified, and the patients that had plasma genotyping performed at the time of diagnostic tissue biopsy, the median time from tissue biopsy to receipt of an effective therapy was 10 days compared to 19 days in our retrospective cohort. When we looked at the whole cohort overall, what we found was that in our prospective cohort, the median time to treatment was 12 days compared to 20 days. So, by performing plasma genotyping at the time of diagnostic tissue biopsy, we were able to demonstrate that patients had significantly decreased time to treatment. So next slide. So this is just a schematic diagram of how this process worked. So you can see that on day 0, this is a patient with a CT scan that's concerning for advanced non-small cell lung cancer. This is a patient that was evaluated in our interventional pulmonary clinic for an abnormal CT scan, and they were scheduled for bronchoscopy the following day. You can see on day 1, blood is drawn and sent for plasma genotyping, and bronchoscopy is performed. Path results return on day 6, showing a poorly differentiated adenocarcinoma, and the tissue is sent reflexively for next generation sequencing. On day 7, the plasma next generation sequencing results return, revealing an ALK rearrangement. The patient's oncology provider is notified of these results. And on day 12, an appropriate targeted therapy is ordered prior to the upcoming visit at our institution. On day 13, the patient sees the medical oncologist and leaves with that medication in hand to initiate treatment as soon as they leave that visit. And then the tissue next generation sequencing results don't come back until day 20. So this just kind of shows an example of how this process worked to really significantly decrease the time to which patients receive the therapy. Next slide, please.
I love that last example. And that's really what we've tried to do as well. When you're doing same day blood draws as the bronchoscopy or diagnostic procedure. And, initially, I think we got a lot of pushback from this. I got a lot of pushback from oncologists. Now, this is 5-6 years ago. And the initial thought was, you are not an oncologist. You shouldn't be ordering this test. And I think that we've come a long way since then. So what kind of challenges do we see out there for places that want to institute this and start sending off tissue and plasma the same day in the same procedure?
I'll quickly just highlight that we did survey our oncologists, and everyone was actually thrilled with the study, as Dr. Agarwal can attest. But one critical aspect of this study, and this kind of goes back to the importance of multidisciplinary treatment, across the care continuum, is really communication. And I think that downstream communication is critical for the medical oncologist to know that you're ordering these specific tests, and that there's kind of closed loop communication of when these results become available. So they know that this test is kind of out there pending, so things don't get duplicated, that they're aware when these results are returned. I think that's really critical, and I think the success of such a strategy is really dependent upon different institutional structures.
At my institution, we had some of those initial things, and some of the ways that we went around that is, number one, really utilizing our nurse navigator as that go-to person and saying, hey, I sent off plasma or we sent off tissue or whatever, and kind of letting them take over that. I think that's another place where we can really start having these conversations with patients very early on. I think it's incumbent upon us as pulmonologists, interventional pulmonologists, thoracic surgeons to have these conversations with patients too, to say, look, we're doing all this testing. There's a reason why we're doing this testing, because I'm sure it happens to you every single day. A patient comes in and says, I saw this medicine on a TV commercial during the Super Bowl, and that's the medicine I want. And so trying to offset some of those expectations that we can do proactively in the office. That last example you just showed, we know that patient has advanced disease. We can start having that conversation early with them about what we're doing, why we're doing it.
Yeah, and I think, Dr. Agarwal kind of highlighted a lot of the, data that's out there showing that, even though we have targeted therapies at our disposal and the importance of biomarker testing, still the majority of patients don't get appropriate biomarker testing prior to initiating a first-line therapy. In my opinion, the more providers that are thinking about this issue, thinking about testing, communicating to patients about the importance of the more biomarker testing, the more likely that it is to be accomplished. And I think that pulmonologists really being knowledgeable about biomarker testing, ensuring that patients are getting sufficient tissue for downstream biomarker testing, being able to order liquid biopsies and understanding the utilization of plasma genotyping, and I think oncologists have been very excited to see that patient, that first medical oncology visit, and have the molecular test results in hand so that they can have a more informed discussion with the patient and initiate treatment sooner.
In my opinion, from a pulmonologist and probably thoracic surgeon standpoint, it's no longer acceptable for us to say, hey, this isn't our job. We really have to be part of this team and think about these things, discuss these things, and order these things ahead of time. Because as you guys have shown with your own data, and congratulations for really getting this message out there. And that's why we don't really have to get into the next two questions, because you really eloquently showed that in the data that you just presented, that it makes a big difference in time to treatment. And you showed a specific example where it really makes a difference. And when you get a hit on that plasma biopsy, you can take it to the bank. But importantly, if you don't get it, don't stop there. All right, let's go to the next slide, and we'll wrap up with the last section and then go into some Q&A. So we'll talk about implications of coordination of care, and this is really what I kind of call the kumbaya slides, the let's all work together. This is a team effort. But as we mentioned several times, the pulmonologists, whether it's an advanced bronchoscopist or general pulmonologist or interventional pulmonologist, they can really help to ensure proper acquisition, handling of the tissue. So again, we need to be more mindful of the practices and how to process tissue. So we really can't say enough that it's incumbent upon, what these groups used to call the tissue takers. And so we didn't like that term. We wanted to come up with something special like tissue special ops, or something that made us sound a little bit more intelligent than just tissue takers, even though that's what we are. But again, just getting tissue is not enough anymore. We have to make sure we get enough tissue, that we handle it properly. And it's incumbent upon those tissue takers to do it the right way and really implement a coordinated and evidence-based approach for your hospital. The other thing that we've done is we've had this kind of molecular pathology. I'm at a community hospital. We don't have molecular pathologists. We have pathologists, and we're lucky to have very good ones. But we have this molecular board that we meet every quarter, because the goalposts are constantly changing, and we all have to make sure that we're on the same page with ordering this stuff. So it's important to constantly have these meetings to make sure that we're all coordinated, that we're staying evidence-based, because again, the evidence is constantly changing. The NCCN guidelines are constantly updating. And so we want to make the proceduralists really aware of how important their position is in terms of having preemptive conversations and collecting the tissue and sending off liquid biopsies. Next slide. All right, so again, this is the kumbaya slide, but the important part of this is don't forget that the patient is in the middle of this. It's not about me, it's not about the pathologist, it's not about the oncologist, it's all about the patient. And so honestly, I think that this message has really gotten to the vast majority of these people. In my opinion, the one person or group on this slide that probably is not that much into this or included in this process is the interventional radiologist or the radiologist. We should be able to put some information together. Hey, if you're doing a liver biopsy in a patient who has a lung mass, that's stage 4. You need to reflexively send this off. And typically radiologists have been very hands-off. So we have to come up with some ideas of how we can include the radiologists in this. That's where I see one of the biggest limitations. But I think we probably have some work to do on the radiologist front as well. So we'd like to get them more involved. Next slide. So again, the key takeaways from the entire webinar tonight, and again, we were very lucky to have two experts with Dr. Agarwal and Dr. Thompson, and specifically present their own data that they've published. And so we've talked about, making our treatment be driven by diagnostic testing because it's been found in their data to increase overall survival. We want to do and encourage concurrent tissue and liquid biopsies, and ideally we mean really concurrent, like the same day. Send this off together. You saw Dr. Agarwal that she has a meeting with the patient and she's ordering the liquid biopsy and then has to see them again. Our oncologists would go nuts. They're like, we don't have enough appointment spaces to be able to do that, so they won't see them until they have at least the liquid back. So that's not always practical everywhere. So we want to try and do these concurrently if we can. And molecular testing earlier in the diagnostic journey, as you've seen from their data, really accelerates the time to treatment. And we have to recognize our roles as pulmonologists, that we're not just tissue takers anymore. We have to know about actionable mutations, and that's really what this whole talk is all about. Next slide. All right, so we'll open it up for Q&A. We have a few questions in the chat box, and feel free to type in your questions. We have a few minutes left here to do this. So the first one is, for somebody trying to implement this protocol, where would you recommend that they start? You guys have looked at this data both at academic centers and your community centers. There's somebody here from a community center and they're saying, this is a great idea. How do I implement this? Where do I start? What do you say to them?
And when you say this, is it reflex testing, or is it doing liquid biopsy at the time of diagnostic biopsy?
I think all of the above. They really just want to implement the things that they've learned here tonight from this talk.
I think it starts with multidisciplinary discussion. I think people have to get in the same room physically, I think, technically, either virtually or in person, to really discuss what issues are there that are preventing them from doing fast turnaround on some of these issues. So whether it's incorporating reflex testing, or whether it's really coordinating a liquid blood draw at the time of diagnostic testing, I think it starts with that multidisciplinary discussion, which is, I think, central and key. Pathologists need to be involved, so that for smaller centers that may not have in-house molecular testing, the pathologists have to be comfortable with sending those slides out to an outside lab for molecular testing.
Yeah, I completely agree. I think it's really identifying your stakeholders and getting a multidisciplinary group in the room, and just mapping out a process of how to accomplish these various tasks, and getting feedback from in a multidisciplinary fashion, iteratively, about how to kind of implement these strategies.
Yeah, and my answer to that question is, in my opinion, you have to identify a champion, and it doesn't matter who it is, whether it's a pulmonologist or a thoracic surgeon or a pathologist or a medical oncologist. You need a champion at your site to start bringing together these stakeholders. And if you have a multidisciplinary meeting, and I think that we automatically assume that everybody has this, but I think in smaller community centers, it's not always that common. They may not meet every single week. They may only meet monthly, and that's kind of a problem. So you really have to identify a champion, and if you're asking the question, you volunteered yourself. You're the champion at your site, and you've really got to get out there and show people the data. Look at the footnotes from this talk, and look at the studies by Dr. Agarwal and Dr. Thompson. Take those studies to them and show them that it really does make a difference. In my experience, I think a lot of people start to have this nihilism. We've had diagnostic and therapeutic nihilism for so long. We've said, oh, well, it's QNS. Well, they're a long-time smoker, so they probably won't have a mutation, so we won't send it off. We need to get rid of that kind of thought process. So another question, what are some of the best practices for ensuring the liquid biopsy samples are ordered for patients? And kind of a corollary to that, there's another question that goes along with this is it possible to have the pathologists order liquid biopsy reflectively? What are your thoughts on that? It's an interesting concept.
That's a very interesting and provocative concept. I think it would be hard as they're not interacting with the patient. And I think that may be one key barrier to implementing this.
And I would say, one thing that has facilitated liquid biopsy ordering is if you can try and implement the ordering process into the EMR. I think, that has been, instrumental in kind of facilitating, liquid biopsy ordering. You talk about inertia as a barrier to instituting biomarker testing. I think if you have to kind of track down a manual requisition, fill out a long form, that, is just one, additional barrier to try and, get, appropriate testing in patients in an already busy schedule. So as much as you can do to streamline that, and that gets back to kind of institutional resources, bringing in, streamlined ways to kind of order these things to make it easier for the providers to order these tests.
Yeah, I think that's a great point. It's a big barrier. During my procedure now, I just, call out to my nurse, I want to send off this test. She asked me a couple questions. Is this initial or recurrent disease, and what stage? And I answer those literally right when I'm in the middle of doing the procedure, and it's done. So I completely agree. We want to hit the easy button on this. Any closing thoughts? We're done with the Q&A. Do you guys have any closing thoughts? I really wanted to thank you for being here.
No, thank you for the opportunity. I think this is an important issue, and I think the more people, particularly early providers like pulmonologists, thinking about biomarker testing, I think the more we can help our patients ensure that they're getting appropriate biomarker testing.
Thank you again for having me, and I couldn't agree more. I think the only way that we can really deliver precision medicine is by testing.
Great. Well, thanks to both of you. Thanks very much to AstraZeneca for sponsoring this, and to the Society for Advanced Bronchoscopy for bringing this webinar. Hope you all have a great night. Take care.